Go to the next one. This is about hemodynamics. Hearing from the experts about the past, present, and future. We go to Bangalore, where we have Dr. Harish from Narayan Hridayalaya, and interviewing him would be Dr. Rajendra Vajrapu. He is the head and senior consultant from Aware Gleneagles Global Hospital from LB Nagar, Hyderabad. So over to you, Dr. Rajendra and Dr. Harish.
Good afternoon, all of you. Today we have an interesting session, hemodynamics, and we have Dr. Harish MM. He's well known for all of us. He's in charge intensivist at Narayan Hridayalaya, Bangalore, and we'll discuss about hemodynamics in this session. And first of all, I would like to thank the CRITIC 2021 team for organizing this session with both of us. And I hope you will have some insights about what's happening in hemodynamics management. Dr. Harish, would you like to elaborate on the progress that has been happened in the front of hemodynamics in the past and till the present?
So yes, absolutely, Dr. Rajendra. So good evening, all. So this is the session which is filled with lots of scientific issues. That is a CRITIC 2021. So happy to be a part of it. So when it comes to hemodynamic assessment and management, here we have two considerations. One is the assessment, one is the management. So in the assessment, we had lots of like continuous versus that of the intermittent devices, and lots of invasive, minimally invasive, and that of the non-invasive gadgets in the last one and a half to 2 decades and all. So basically, when we have a gadgets and that of the parameters, so we need lots of validation across different category of the patients, perioperative area, medical intensive care, so post cardiac surgery or any sort of major surgical patients. We need a proper validation in terms of its credibility, its sensitivity and specificity. So most of the gadgets which came into the market definitely have some sort of pros and cons. So as I told, like from non-invasive, minimally invasive and to the invasive, most of the devices what we have used it currently, which may be like pulse induced counter cardiac output monitoring, PICO, volume U, and that of the pulmonary artery catheter, which is a thermodilution method, most invasive method, and that of the minimally invasive method, we have esophageal Doppler. So we have like flow track, Vigilio monitor. Non-invasive, we have lots of bioreactants, bioimpedance, and lots of we'll discuss further. So when it comes to therapy, when it comes to management, lots of things changed in terms of the hemodynamic troubleshoot, from using the like norepinephrine to vasopressin to like angiotensin II, and that of some like infusion therapies like Centacvid, which is the newly came into the market for like resuscitation of hypovolemic shock and all those things, and the utility of the steroids. So basically, the monitoring and that of the management has evolved in the last decade in a major way in the pros and cons of each intervention, each modality is having its own advantage, disadvantage. So that is the progress. We have to wait for how the future is going to happen.
Yeah, nice, very nice. So we all know that right from the small centers where we do clinical monitoring like capillary refill, urine output, conscious level, to the level of what you have described, has hemodynamics monitoring and management has come to it, has taken long strides for the benefit of the patients. Very nice. So what are the advances that are on the horizon of management of hemodynamics?
So when it comes to still more advances in terms of understanding hemodynamic status of a patient and management of the hemodynamics with a proper monitoring at the bedside, as we already know that so clinical and one that is the monitoring gadgets and all. So we have some sort of advances like venous to arterial PCO2 gap, and some sort of changes in the partial pressure of the CO2, and we have very advanced gadgets which works just based purely on the non-invasive, so like photoelectric plethysmographic methods and all those things. So along with that, we discussed lots of in and around the utility of the capillary refill time at the bedside, and some gadgets which works on changes in the frequency of the current or that of the impedance resistance when there is a happening of systole and diastole in the thoracic cavity. We have bioreactance, impedance, and all those things. So as I already told, so we need a continuation, a continuous monitoring, which is very minimally or non-invasive. With the same time, it should be very well validated and which should be accurate. So that is what we are looking for in terms of advance in the hemodynamic monitoring and that of the management. So which we have already couple of gadgets in the loop, and we used all those things. But the evidence is still evolving, so we have to get idea in different scenarios with a good published data and all.
Absolutely. Not only technological advancement, its utility and ease of use and validation is very, very important.
Yeah.
So recently, a lot of people got COVID and they're being managed at home. Pulse oximeter has been the main source of identification of sickness of the patient, how they are progressing in COVID. In that, I observed one in the latest pulse oximeters, one PI. In the pulse oximeter, it is written as PI. What is PI in the pulse oximeter? Whether that is useful in the ICU setting also.
As you already mentioned, so this technology has been evolved in the era of this COVID in the last 2 years, because we were searching a gadget which should be very ultimately totally non-invasive kind of this one. So easy to use, easy to understand, easy to interpret kind of this one. So we were not bothered about its limitation and all. We want such a gadget which should be like easy overall kind of in a clinical utility. So that is one indices, that is a perfusion index. So basically it is not a new concept per se. So they made this concept into some sort of the gadget. So that is what they have done with a technology called Messimo. Even a BPL like company also introduced this concept, perfusion index. So what exactly the perfusion index means? So it is a ratio of the high volume to that of the weak pulse, means pulsatile to that of the non-pulsatile arterial waveform. So basically when we have a very good volume pulse, so it means the perfusion is adequate, vasodilatation kind of this one. So when we have a very weak pulse, so the perfusion is been hampered. So we have a, some sort of range somewhere between 0.02 to 20. So that is the range of a weak pulse to that of the very good volume pulse kind
strength of the pulse, you mean to say?
Yeah. So that is the perfusion index. But we need to understand when it comes to clinical utility, so most of the data available in a perioperative area. So again, it's questioned its credibility when a patient is moving, motion artifact, severely vasoconstricted state, or when a patient had edematous peripheries and all those things. So that is going to have an impact. And one more thing you need to understand on this perfusion index, as I already told, good volume and weak pulse kind of this one. So there is no fixed value for any particular patient. Okay, so we need to measure what is his baseline perfusion index, and we need to trend it. We need to see the changes in the perfusion index. So that we need to understand. But as I already told in COVID, so basically it gives us some sort of idea something is bad. So that is good, at least. Means than not doing anything, at least if you are able to identify. So you measure one perfusion index value and you trend it, what's happening kind of this one. So that Messimo is one apparatus, means which introduced this perfusion index with some sort of evidence and all. As I already told, which needs validation across different scenarios, different kinds of shock in the ICU. If you ask me, can we straight away use it in the mixed pathophysiology intensive care unit? Currently, answer is no. So we need more data on its utility.
Okay. So will that suggest that we need to start vasopressors, fluids part is over, vasopressors it needs any number to target or any number of PI that suggests that vasopressors are, this is the time you start vasopressors?
No, the particular cutoff number is difficult to tell. So as I already told, even in each individual, it depends upon the dynamicity of his changes in the hemodynamics and all. So then it varies between 0.02 means very weak pulse. So 20 means good pulse kind of this one. For that person, perfusion index of 14 may be adequately perfusing his organs. So basically, we have to tag that perfusion index with that of the other perfusion markers. Means if he's having a good urine output, good sensorium, lactate is trending down, kind of this one. So peripheries are warm. So why to bother about any particular number of?
Maybe in a reasonably stable patient we may use it, but may not be ideal for sick and hypotensive patient, right?
Yeah, definitely.
So other thing is we have been using the CVPs, MAPs, mean arterial pressures, so many heart rate. All these are static parameters. So will that affect only monitoring these and going for the therapy, or do we need to go for any dynamic parameters? What is your idea and suggestion?
Definitely. So we need the dynamic parameters and all. At the same time, we can't absolutely throw away the static parameters, because if I ask my resident, okay, are you going to use the CVP in the ICU? If the answer is no, I'll get anger on him, because CVP and the pulmonary artery occlusion pressure, the concept has to be very clear when we want to move to the dynamic indices and all. So basically, we need to understand what exactly is the dynamic, what exactly is the static. So any parameter, so that will not taken into consideration of heart-lung interaction, means what is happening to the stroke volume or the cardiac output in relation to inspiration and in relation to expiration, in relation to whether a patient is on positive pressure ventilation or spontaneous breathing. Any parameter which taken into consideration of all these interaction, cardiopulmonary interaction, that we call it as dynamic indices. So obviously, so static indicators will not taken into consideration. So CVP high doesn't mean at all. So it may be because of increase in pleural effusion, pneumothorax, intra-abdominal pressure and all. But one thing we need to understand, so they try to dissect the trend utility of the CVP than seeing the single value of the CVP and all. So again, there are some concept about something called delta CVP. All those things has been introduced. It means change in the CVP from the baseline after deep inspiration for 1 minute, means like that is delta CVP and all. So we can't throw away the static parameters. They are the mother, father for the development of the dynamic indices like pulse pressure variability, systolic pressure variability, stroke volume variability. But these dynamic indices also have their limitations. Like the tidal volume should be 8 ml per kg, no arrhythmia. So there should not be restrictive lung disease, and there not be any sort of spontaneous breathing and all. So right ventricular dysfunction should not be happen. So each parameter, so we need to understand its limitation and the scenario where we are using. So that's very important.
Basically, it's a stress that we impose onto the system and see how that is responding. And accordingly, the fluids, whether patient will be responding to fluids or not, we'll be able to understand accordingly. We give. That's right.
Yeah.
I want to hold the recording a bit. Noise is there from your end, or?
I think my end, some construction. It's bothering too much.
Yeah. Can we ask them for 10 minutes? They can hold.
I think Rajendra, it's in the 7th floor. I think.
Okay. Fine. Then go ahead.
Yeah.
So what about MAP? So mean arterial pressure, we tell our residents to target MAP of 75, 60, 65. So MAP is a good parameter to monitor, or any specificity about when it is not useful, when it is useful, when to target a better MAP, when to accept the lower MAP for each patient. MAP 65 and more is good enough for in every patient. What's your recommendation?
See, when we use the mean arterial pressure, so we are using it as a surrogate marker for the perfusion pressure. But we need a individual tissue perfusion pressure, so that is not possible. Like we know that central means like brain perfusion, cerebral perfusion pressure, that is mean arterial pressure minus that of the central, that is the intracranial pressure, kind of this one. So like that, we need an individual organ perfusion pressure, but it is not possible. Obviously, we use the MAP as a global indicator of the vital organ perfusion. But we need to understand. So high MAP doesn't mean they are not in shock, kind of this one. So shock is a multisystemic end organ hypoperfusion. So it is not linked to the blood pressure. So shock can happen with the normal blood pressure also. Even that is true for cardiogenic shock also. Even about 15 to 20% of the patient with the cardiogenic shock, they retain their blood pressure because of the compensatory systemic vasoconstriction, peripheral vasoconstriction and all. So basically, we use one marker as a surrogate marker for the vital organ perfusion pressure, which is bit easy to monitor, which is bit continuously able to monitor, which is bit able to get an idea about the trending of the mean arterial pressure and all those things, and we can target some particular value. So when it comes to particular value, so anything we want to do supraphysiological means, okay, so if you create the map of 85, 90, so patient will be all right maybe in the next 24 to 48 hours. That is being disproven. So that is being disproven by a trial called sepsis PAM trial, where they tried to compare 65 to 70 versus 80 to 85. So that is applied only in a particular group of patients, those who are having a history of chronic hypertension. Probably they are having some sort of renal dysfunction and all. So if you try to target the same map of 80-85 in a patient with non-hypertensive, so then leads to lots of problem with arrhythmia and all, because you pump lots of catecholamines, lots of vasopressor agents and all. So that is not correct. And again, as I already told, supraphysiological we don't want. So that is being proven in high cardiac output. Okay. So we want to have a cardiac output of 8 liter, 10 liter. So increased morbidity, mortality. So we need some
study.
Yeah. So some perfusion indices for that particular patient, for that particular scenario. It is some sort of supply demand depending upon their innate compensatory mechanism, their comorbid, premorbid condition. So basically it is okay to use MAP, but we need to understand the limitations of MAP. So an adequate MAP does not rule out is totally well perfused kind of this one. So that we need to understand.
And other thing is each organ system MAP requirement is different. Coronary perfusion pressure requirement may be different than cerebral perfusion pressure or renal. So each and if you limit that to, if you oversimplify, that may not be working for the specific organ. And sometimes in aortic regurgitation, MAP may be low. Organ demand, tissue demand is not much. So organs are well perfused. That's right.
Yes.
So any other only single parameter is good enough, or you need to consider evidence from other parameters also to take care of hemodynamics?
So basically, so you see the map, what's happening to the map. You see the urine output, you see the peripheral perfusion, capillary refill time and all. You see the trend of lactate. If you don't have any confounding factor for the haphazard appearance of the lactate, like is not on adrenal infusion, not on any medicines which create the problem with the lactate and all. So then understand, so how the patient overall means, what is his oxygenation requirement? So to what antibiotic is responding? How much is his vasoactive agent requirement? How adequately the source has been controlled? So what category of immune status the patient is having? So basically clinical biochemical parameters we need to integrate, trend it out to understand and to manage further on the go at the bedside. So we can't rely totally on the map. So like PCO2 gap. So everything we can, like we learned about the central venous oxygen saturation, mixed venous oxygen saturation and all. So all are having its own place, but we have to comprehensively club together everything to understand. So where is our particular patient in the array of resuscitation? That's very important.
So basically corollary evidence of the similar like hypotension is because of hypovolemia or cardiac index. So multiple evidence should be there to guide the therapy, right? Instead of taking one
value.
So I have a patient who is in refractory septic shock. I have used all sorts of fluid management, vasopressor, like noradrenaline and dobutamine to improve the peripheral perfusion. And I have tried steroids, and I have tried vitamin C, thiamine, all this. So any role of methylene blue in such patients?
So this is one like some sort of pharmacological therapy which make a little bit peep in during the COVID era also. So here and there we heard, okay, methylene blue in COVID. And it is not a peeped in molecule, very newly into the array of resuscitation, which is being used previously also. So the rationality for methylene blue, it's in a clear way. So it is going to prevent the means like nitric oxide induced conversion of GMP into cyclic GMP, so that like which helps in preventing that vasodilatation. So means vascular relaxation it's going to prevent. So that there are couple of studies. Hardly the studies included 30 patients, 40 patients. Maximum data published is a open labeled non-randomized control trials around 40-44 patients. They were able to demonstrate in sepsis, severe sepsis, septic shock and all, they were able to wean off the vasopressors, means vasoactive agents a bit early when they used methylene glue and all. But the problem is we don't have a standardized dosage till now. So some studies they used bolus of 2 milligram per kg, so followed by 0.5 milligram per kg per hour for 6 hours. Someone has given 4 milligram per kg, someone has gone up to 20 milligram per kg, kind of this one. So adverse effect, worst thing what can happen is methemoglobinemia, kind of this one, some discoloration of urine and skin. But really speaking, we need a very good confidence, very good evidence in and around this molecule.
So any experience, personal experience?
With some family demand and all, in this COVID, we have used in 2-3 patients when they got all these news circulating in different social media and all. But one patient survived, so it's very difficult to conclude he has been survived because of methylene glue and all. Rationality is good, but we need it to be proved on the paper, kind of this one.
So, and recently Angiotensin II, FDA has approved as a new vasopressor for septic shock. So how do you see the utility of this new agent?
Yeah, definitely. It has been recently approved by FDA. So very good, well-conducted study, that is ATHOS 3 trial. So clearly suggests in a vasodilatory shock, distributive shock, so which helps as a like vasopressor catecholamine sparing agent, that is the angiotensin II. So that is being proven, very good study. But if you review the literature, so now they are looking into the utility of the angiotensin II. So basically angiotensin II causes the like action at angiotensin receptor 1, so which is going to cause like vasoconstriction and all. So they are categorizing the utility of angiotensin in a sicker patients, those who are having an underlying acute kidney injury, so liver dysfunction, ERDS or cardiopulmonary bypass, or those patients who are in ECMO, kind of this one, with a high severity indices. Data is good and some data is in the pipeline also, but I am happy to use it, suppose like if it is available in India, so in a broader way. But one thing we need to remember, the comment even after criticizing the ATHOS 3 trial and the recent evidence in the some review of literature and all, so we can use this angiotensin II if you are able to demonstrate the patient is having a low angiotensin II level, or there is an abnormality in the angiotensin receptors. They have done some assessment of angiotensin 1 to angiotensin II ratio. So basically these 3 parameters they are thinking like to evaluate before going ahead with giving angiotensin to all the vasodilatory shock, kind of this one. So this is the comment from the evidence. This is something we need to remember, but it is worth exploring this molecule in a patient who is going to have a some sort of vasodilatory shock. Again, one more $1 million question is whether we need to use afferently, means timing. So or after norepinephrine, or after vasopressin, or after giving a steroid, that things to be clarified in the coming literature.
Another important thing what I came to know is thromboembolic phenomena is very high in this set of patients who have been using angiotensin II. So mandatorily they have to use anticoagulants. So what is hypotension prediction index? Something new word has coming up. Any idea about hypotension prediction index?
So this basically, it's a commercially incorporated protocol based on this like index called Hypotension Prediction Index. So it looks very attractive. So it has been introduced in the Edwards life science monitoring device. So basically it is the like number of episodes of hypotension, that is the mean arterial pressure less than 65 persisting for 1 minute. So the range is 0 to 100. So again, like somewhere it is more than 80 means it is bad. So they used this hypotension prediction index with an algorithm. So whether we can troubleshoot with giving the like afterload support, that is the vasoconstriction, or contractility support, or that of the preload support, that is the volume. So basically after a particular hypotension prediction index, means like if the value is more than 80 kind of this one. So then like you assess for the stroke volume variability and you assess for the something called dP by dt. So that is the left ventricular pressure change in a 1 minute of isovolumetric contraction that tells about the LV contractility. And there is something called arterial elastance indices, EDINE. That is the like pulse pressure variation divided by that of the stroke volume variability. So that tells about afterload. So dP by dt tells about the contractility. SVV tells about some sort of the preload requirement. So it is a fixed some sort of algorithm. But if you see the evidence, there are some pilot study published. So the sustainability of this so-called episodes of hypotension were very fragmentous, means not even for 1 minute, to take them into consideration of hypotension prediction index and all. And they used some cutoff value of more than 80. So many patients were not in a requirement of any of these manipulation. That was very very transient value of the hypotension happened. They really don't require to troubleshoot with some sort of changes in the preload, afterload, or that of the contractility kind of this one. So that was the pilot study published based on this like commercially available algorithm and all. So very good concept.
So is it valid in ICU setting or perioperative only?
So basically they are looked into perioperative patients, initial data, whatever available. So it's very difficult to extrapolate the data into like multi-speciality where we have a continuous dynamicity changing on the floor kind of this one. So we need
last question for you, because I want to keep asking you more questions and enlighten the audience and including me. Last question for you, but time is not permitting. So what about how do you see the non-invasive modality like ultrasound in the management and assessment of hemodynamics?
Yeah, so definitely ultrasound is one of the easily available gadget, repeatable. So with a minimal training, we can incorporate at the bedside and it is totally non-invasive. But some things, the problem with ultrasound, it is a non-continuous. Even it is repeatable. So we can't keep like probe attached in the pericardium, means precardium kind of this one. But with that limitation also, quickly we can get an idea if the heart is the culprit for hypotension, hypoperfusion, or heart is not the culprit. So if you are able to negotiate, okay, it is not the heart is the problem kind of this one. So then still again we can consider using echo findings with the other findings of biochemical markers, okay, clinical scenario and the trend of all these parameters in the hemodynamic resuscitation and all. So if you see the poor contractility, what we call it as eyeballing, so then like is already having some sort of B lines kind of this one, is IVC, no respiratory variability and all. So then we are a bit careful about pouring him with a fluid and all. So there are some attempts has been made, okay, we can try to understand changes in the velocity time integral. So you measure VTI in the like apical 5-chamber view by putting the Doppler and all. So again, remeasure after putting the patient on PLR and all. So don't do that at the clinical end, because so you need to keep the probe there only. It is very subjective. If you move the probe here and there, so the value is not validated. So it is a very good concept to see the PLR changes relation with that of the VTI, maybe carotid VTI, so brachial VTI or aortic VTI and all. So, but it is practically difficult. Whatever mentioned, all these like some sort of limitations and all. So I found echo is a bit useful gadget. And don't get passionate about IVC kind of this one. In a spontaneously breathing patient, IVC is nothing kind of this one, because if patient breathes like this, it is
like metabolic acidosis. A lot of negative pressure and variations. Too much variation can be.
But still, like if you understand all these existing limitations, we can still consider echo is one of the non-invasive good modality of hemodynamic monitoring at the bedside.
Thank you, Harish, for one session. And a lot of technology is evolving, and actually whether that is really helping the patient who are in need at the distant place, maybe missing the bus. So more and more miniature wearable sensors which can transmit signals to the command center. That's how we can pick up the sick patients early, and all these technologies should help to identify early and treat them with appropriate management protocols and evaluate continuously and get things better. I hope in the near future all this will happen. and we'll be keep talking on these topics. Thank you very much, Harish and the team.
Yeah. So thank you. Lastly, I just want to tell, see, basically we have to like integrate, so interpret and intervene. So that is very important. Integrate everything. So whatever you get, biochemical, clinical, gadget based, so integrate, interpret, then you intervene. So
Exactly.
that's very, very important in terms of hemodynamic model.
Nice.
Thank you.
Thank you.
Thank you all. Thank you.